Hi, in this case study for Bio 2263, we're going to look at the case of a woman who has a pituitary adenoma. And we'll start with her history. She's 22 years old. Her name is Shelley. She recently completed her college education. She did attend college on a basketball scholarship and has played basketball since she was 9 years old. She's 6 feet 3 inches tall, so quite tall, been the tallest kid in her class since 3rd grade. While it used to bother her to be so tall, she did benefit from it through basketball. Here she is a year ago. Here she is on presentation. She just got married a year ago. She's had recurrent headaches all through high school and college, but nothing she couldn't deal with, and usually treated them with over-the-counter non-steroidal anti-inflammatory drugs. However, the headaches have become more frequent in the past few weeks, and now she's experiencing tunnel vision as well. She did have orthodontic work as a teenager, but had her braces removed when she was 17 years old, and she wears a nightly retainer. One of her current complaints is that the retainer doesn't fit anymore, and her teeth seem further apart than they were in the past, with spaces between her teeth that weren't there before. But her main complaint today is amenorrhea. She hasn't had regular menstrual cycles ever. They've always been irregular, sorry about this. But now she has no menstrual cycle, and she's trying to conceive since she was recently married. Other signs and symptoms on presentation include galactorrhea. Galactorrhea is milk production, so the breasts are producing milk even though she's never had a child. Polydipsia and polyuria. Polydipsia is increased thirst, and polyuria is increased urination. Her wedding ring no longer fits. She has not gained weight. It's only been a year since she was married, but her wedding ring no longer fits. She has those headaches, she has tunnel vision, and she has diastema, spaces between her teeth. On physical, her pulse is normal, her blood pressure is normal. She is tall with long arms and legs, but all are proportionate to her stature. She has enlarged hands and feet. And in her facial features include excessive hair, excessive hirsutism, a prominent brow, an enlarged nose, and those spaces between her teeth, diastema. She also has galactorrhea. So the relevant signs and symptoms that we need to consider are the excessive height, large hands and feet, and facial changes, the amenorrhea, galactorrhea, the headaches and tunnel vision, and the polyuria and polydipsia. So we're going to do some tests on her because with that excessive height and those changes in the face, we do suspect that she has an excessive growth hormone. As a child, an excessive growth hormone causes gigantism or giantism, where they grow excessively in height. But as an adult, once the growth plates are closed, the excess growth hormone causes the disorder known as acromegaly. So let's check her blood levels for growth hormone, and her blood levels are high, 23 when it should be less than 1 nanograms per milliliter. But you know, growth hormone levels vary throughout the day, so to be sure that she actually does have high growth hormone levels, we're going to do an oral glucose tolerance test. So an oral glucose tolerance test means give her some sugar solution to drink, and normally high glucose will inhibit growth hormone. So after she drinks that high sugar content solution, she should have a decreased growth hormone level in her blood. But for Shelley, after that oral glucose tolerance test, she still had the same high growth hormone levels in her blood, almost 10 times higher than normal. Her insulin-like growth factor 1 also is quite high here. Growth hormone stimulates the production of insulin-like growth factor 1, and it's actually that IGF-1 that causes the growth of muscles and bones. But anyway, that's high, growth hormone's high. Her blood sugar also is high, her glucose levels, and her glycosylated hemoglobin level is somewhat high. Glycosylated hemoglobin means hemoglobin that has some sugar attached to it or has been damaged by sugar, and this shows us that her blood sugar levels are not just high today. They've been high for at least a few weeks, because when the blood sugar is high weeks ago, it will change the hemoglobin to glycosylate it, and you'll see that high. So we see high glycosylated hemoglobin in her, showing that she has had this high blood sugar level for a while. I'm going to do an MRI, and on an MRI we see a mass. It's a paracellular mass. Paracellular mass. Cellular for sella turcica, and so she has here a mass next to his para, her sella turcica. Remember the sella turcica of the sphenoid bone? And what sits in the sella turcica of the sphenoid bone is the pituitary gland. So she has a pituitary mass, which we suspected from the beginning because of the excess growth hormone that she contains, and growing tall in height, and these masses are generally benign tumors of the pituitary gland. But just to show you here, this blue arrow is pointing to the optic chiasma. The optic chiasma is just superior to the pituitary gland. So where is the pituitary gland found? Well, here's the pituitary gland right here, and the pituitary gland is found sitting in the sella turcica of the sphenoid bone. So it sits in the sphenoid bone, that sella turcica, that Turkish saddle. And here is the pituitary gland kind of hanging off the base, or connected to the hypothalamus, hanging off the base of the brain, connected to the hypothalamus right there. And so just superior to that pituitary gland we find the optic chiasma. Optic chiasma, remember that optic chiasma right there at the base of the brain? That X-looking structure, it's where the optic nerves here cross, a portion of the optic nerves cross to the other side of the brain. So this green one crosses to the other side, this blue one crosses to the other side. That's where information from the retina of each eye travels up to the optic nerve here, and then at the optic chiasma, part of it travels to the other side of the brain. Which part is it that travels to cross over at the optic chiasma? Well, let's follow. See these green fibers right here? These green fibers are coming from this portion of the retina of the right eye, but more relevant to that is it's coming from the peripheral vision here of the right eye. So we have the peripheral portion, visual field of the right eye, right there, lands on that part of the retina, and then travels and crosses at the optic chiasma. And here, this blue one, see this blue, these blue tracks is carrying information from the peripheral vision here, or peripheral visual field of the left eye, crosses over at the optic chiasma. So if we have a pituitary mass right here, just below here, pressing on this optic chiasma, then that would cause this information to be suppressed or not able to travel up to the brain. And so Shelley is demonstrating that as she is losing peripheral vision in both eyes. She has tunnel vision, which means she only sees like straight ahead, and she lost that peripheral visual field in both eyes. Besides that, we have a question here that asks about the 6 hormones from the pituitary gland. Do you remember those 6 hormones that the pituitary gland releases? Remember the little acronym we used to tell us what were the 6 hormones? The acronym was FLAT PIG, F-L-A-T, and then PIG, but PIG is P-G, no I. So for the flat pig, the F was FSH, the L was, remember, LH, luteinizing hormone. F is FSH, follicle stimulating hormone. L, LH, luteinizing hormone. The A was ACTH, adrenocorticotropic hormone. And the T was TSH, thyroid stimulating hormone. Those 4 hormones control other endocrine glands. So FSH and LH control the gonads, the ovaries or the testes. ACTH controls the adrenal gland, and TSH controls the thyroid gland. Then we had PIG, and just to, prolactin is the P. I'm not going to be able to write this very well, but prolactin, remember what prolactin does? Prolactin causes milk production. Prolactin causes you to produce milk. And then G is growth hormone for growth. And so 6 hormones, flat, pig. Of those 6 hormones, which 2 are increased in Shelley? Well, she's tall, right? So what's that? Which one's causing that? Yep, growth hormone. So growth hormone's high. But also remember, she has galactorrhea, where she's producing milk, where she should not be producing milk because she has not had a baby. So what's causing the high milk production or the milk production? That's high levels of prolactin. So two hormones that are increased in Shelley are growth hormone and prolactin, the pig, the PG hormones. But there's also two hormones that are decreased in Shelley, and those two are FSH and LH. And we know they're decreased because she has that amenorrhea. And these are the hormones that will control her ovaries, cause ovulation, cause, therefore then, in response to that, the menstrual cycle. And has menstrual difficulties, so FSH and LH are low. Why? It says why are there decreased levels of these hormones? Well, it's a crowding effect. So as that pituitary gland is enlarging, specifically the cells that produce growth hormone and prolactin are enlarging, and they're kind of crowding out or smushing the cells that produce FSH and LH, and so FSH and LH are not being produced by her pituitary gland. It says additionally, if Shelley's tumor continues to secrete excess prolactin, that prolactin will cause decreased production of TRH, thyrotropin releasing hormone. So if TRH is low, remember what TRH does, comes from the hypothalamus, causes then the release of TSH, and TSH then causes the release of thyroid hormone, T3 and T4. So if we don't have TRH, so if TRH is low, then we won't have TSH. If we don't have TSH, we won't have T3, T4, and so she would be hypothyroid. Hypothyroid. And symptoms of hypothyroidism include low metabolic rate, weight gain, slow and sluggish symptoms, mentally slow and sluggish. Everything is slow and sluggish, so heart rate is low, so you have bradycardia. Digestive tract activity is low, so you have constipation. Just everything is slow and sluggish. Also, though, it says excess growth hormone, which Shelley definitely does have, leads to insulin resistance. And so if you don't have insulin functioning like it should, then remember insulin lowers blood sugar levels. So with insulin resistance, you'd have an increase in blood sugar levels. And we do see that in Shelley. We saw her blood glucose levels were high. And in addition, we saw some symptoms from that, the polyuria and the polydipsia. The high sugar in the blood will come out in the urine. And as that extra sugar then is in the urine, there shouldn't be any sugar in the urine, but now you have some sugar in the urine, that sugar acts as an osmotic diuretic and pulls water out with it. So if it's pulling water out, she's losing all this water and producing a lot of urine, so you get the polyuria, and because she's losing all the water in the urine, she needs to replace it, so you have polydipsia, increased thirst, or increased drinking. Shelley has diastema too, and diastema is spaces between her teeth. So she has spaces in between her teeth where she did not have them before, and that's the effect of growth hormone on the facial bones. So with increased growth hormone as an adult, long bones can't get any longer, so the growth plates have closed, so they can't grow in height, but bones kind of widen out. And especially you see that in the jaw. The jaw widens out and spaces develop between the teeth where there was not spaces before. So for treatment, first line of treatment is to remove that pituitary tumor. Even though it's an adenoma, a benign tumor, so it's not cancerous, it's not malignant, it's not going to spread, but it's a space-occupying lesion in the brain. It's smushing out. In this case, obviously, we see that smushing on the optic nerve, the optic chiasma, and also other portions of the brain as she's experiencing headaches. And so we want to remove the pituitary adenoma, and this is accomplished by entry through the nasal cavity and then through the sphenoid bone, transsphenoidal approach. Also, you could give somatostatin analogs to decrease growth hormone levels because somatostatin inhibits growth hormone release. Theoretically, if she had continued to experience the milk production because of her excess prolactin, we could give her a dopamine analog, because dopamine inhibits prolactin release. So she has too much prolactin, we can inhibit it with dopamine, at least theoretically. If it continued to be untreated, the facial changes would progress, and so you would see enlargement of the bone and the brow and the chin and more spaces between the teeth. And actually, if you look, you see actually really changes in the whole face, so that they really look different. And you see a squaring off of the jaw, bigger nose, furrowing of the brow, and kind of just thickening of the bones. Also thickening of the bones of the hand, widening of the hand. Here's the wedding ring on. Wedding ring no longer fits because of the enlarged hand and enlarged feet as well. Also, not shown in the picture here, but with acromegaly that's untreated, excess growth hormone continues, that will cause the heart also, cardiac muscle, to enlarge, and with that there would be a cardiomyopathy that would ultimately cause heart failure and death. A lot of these people that go untreated, they die because of the heart changes. And that concludes this study.